Hello, everyone. Welcome to the United Mitochondrial Disease Foundation's Bench to Bedside webinar series. We're really excited to have you join us today. Shortly, we'll be hearing from a series of speakers on a really interesting topic around the use of rehabilitative medicine in the care of mitochondrial disease patients. But before we get started, I'm going to take care of a few background slides and housekeeping. We always like to start by shining a spotlight on Mitoshare, a really important part of the research infrastructure that UMDF supports. This is our worldwide patient-populated registry. So we're collecting patient-derived data, also clinician-derived data on the platform. We now have a biorepository associated with it. Please, if you're seeing mitochondrial disease patients, please make them aware and encourage them to join the registry. And engage patient community is the only way we can get to the treatments and cures that our patients desperately need. Also would like to put a save the date on your calendar for the 2026 UMDF conference. Next year, we will be in Orlando, Florida, June 17th to 20th, 2026. You can find more information at umdfconference.org. We're putting together a really strong scientific and medical program along with a family program. If you haven't joined us before, we hope you'll decide to come and see for yourself. It's a great way to network with the mitochondrial disease community. All right, well, we are ready to get started. I am going to invite Dr. Eliza Gordon-Lipkin to join me on camera. Eliza, nice to see you. Hello. So Eliza is in an assistant research position at the NHGRI at the NIH, and a longtime friend of the foundation. We've done a lot of work together. Eliza, thank you in advance for moderating today's session, and I'll turn it over to you so you can introduce the speakers.
Thank you, Phil. It's a pleasure today to be able to introduce my colleagues over at the National Institutes of Health. First up today will be Dr. Afua Asante Otu. She's a pediatric and adult physiatrist at the NIH Clinical Center, and she specializes in physical medicine and rehabilitation. At the NIH, she provides care in the GATE lab through the Neuro Rehab and Biomechanics Research section, and is actively involved in research focused on complex neurological and genetic conditions, such as those with mitochondrial disease. Next will be Hannah Hillenbrand. She is a senior staff occupational therapist at the NIH Clinical Center, and she specializes in pediatric behavioral health and physical disabilities. Her research collaborations focus on the fine motor development, sensory processing, and functional outcomes in rare pediatric disorders. Dr. Minal Jain is a senior research physical therapist and research coordinator at the Rehabilitation Medicine Department at the NIH Clinical Center. She specializes in pediatric neuromuscular and genetic disorders with a research focused on movement analysis using wearable sensors. And finally, Beth Solomon is the lead senior speech language pathologist at the NIH Clinical Center, specializing in the evaluation and treatment of speech, voice, and swallowing disorders in medically complex pediatric and adult populations. Her clinical and research interests span head and neck cancer, craniofacial anomalies, and rare genetic disorders. So thank you all to the speakers for sharing your knowledge today, and I'll turn it back to you.
I'd like to thank UMDF for inviting us to speak. I know it's felt like a long time coming with a lot of logistical complications, but I'm glad we're able to come here this afternoon. So just the title is The Role of Rehabilitation Medicine in the Care of Children with Mitochondrial Disorders. The objectives for this afternoon is to identify clinical features and needs of patients with mitochondrial disorders, to describe the roles of RMD or Rehab Medicine Department team members, identify collaborating partnerships, and discuss service needs and resources to consider for future pediatric mitochondrial disorder patients. I'm sure UMDF, you are familiar with this slide showing some of the clinical features of patients with mitochondrial disorders. And so I'd just like to highlight one of the main reasons that someone would get referred to the rehab department are usually in these top four categories, either neurodevelopmental, skeletal muscle with exercise intolerance, peripheral nerve sensory disorders, or any kind of vision loss. Just an overview of rehab medicine. I've realized along the way that a lot of people don't know about rehab unless they need us. So just kind of to recap, our main goal is to maximize function and also to maintain and prevent any further decline. And so we are very big on team effort. So some of the team members that we have are physiatrists, which is the physician, PT, OT, speech, nursing, neuropsych, social work, orthotists, and of course the patient and the caregivers, who are the main players in the team. So just a review of physiatry or physiatry, depending on what part of the country you're from. So what we do is that we evaluate patients with MSK or neuromuscular impairments. We can prescribe specific therapies, assistive devices, durable medical equipment, and medication. And so a lot of what we do is coordinating multidisciplinary care. As I said before, there are a lot of team members and there are a lot of cooks in the kitchen. So we just need to make sure that the patient and the family members are all on the same page to arrive at the similar goal. We also try to prevent secondary complications such as contractures or scoliosis. And then energy conservation and pain management is also big. Just to highlight spasticity, like I showed earlier in the slide, where if there's stroke-like symptoms, some of these mitochondrial patients do end up with spasticity, which is a velocity-dependent increase in muscle tone associated with hypertonia. A lot of times when we say spasticity, people think of stroke patients who have a tight arm, so their arm is flexed, or patients with cerebral palsy who walk on their toes. But any kind of damage to the brain or spinal cord can cause any tightness in certain muscles. And some of the treatments include physical therapy, occupational therapy. Baclofen is one of the main oral medications we use for generalized spasticity that can relax the whole body. Botox injections are not just for wrinkles. We use that for more focal spasticity, if it's in the calves or in the hand or forearm. If it's severe spasticity involving the whole body, I have seen one mitochondrial patient who actually does have a ITB or intrathecal baclofen pump, and that is for severe generalized spasticity. And so in the picture here, you have the pump, which holds the liquid baclofen. So it's about the size of a hockey puck. So patients who are a lot younger, it takes up too much of their abdomen, so it's not recommended. But older patients, maybe around 7, 8, 9 years old, it's the size of a hockey puck, and then the catheter reaches to the spinal cord, and the baclofen goes directly to the CSF. Other times, if there's any spasticity involving the calves causing toe walking, you can either do surgery to release the muscle at the Achilles tendon, or you can do serial casting here in the slide over here, where you put the cast on like it is if they broke their foot, and you progressively dorsiflex them to gain range. So every week you would cut the cast off and then put a new one, hoping to gain some range. And this can be done in conjunction with Botox injections. And they're also given a little boot so they can still walk around and be mobile. Again, rehab is a lot of lifespan of care. So sometimes we say cradle to grave. So we see people in the NICU, we see early intervention, school-based, outpatient, inpatient, even hospice and end-of-life care. And the frequency and intensity of therapies depends on the severity and availability of services. So some patients might compare what they're getting, and it might not be the same, but there are a lot of factors that go into that. So I'm just going to touch briefly on some of those locations that we are most likely in. Early intervention is available for any child in the US with identified developmental delays from birth to age 3. The parent can refer. Usually it's a NICU provider or either social work or the pediatrician. And this can be done online or phone or fax. Usually now it's done online. And depending on the state, there's a different name for it. So certain places it's called infants and toddlers, other places first steps or help me grow, but it's all the same care, which is under early intervention. And so once the referral is made, there has to be an evaluation within 45 days to create the individualized family service plan, which will help the family understand what services are needed. And they can also order equipment and orthotics. So to qualify for early intervention, the child would need to have greater than 25% delay compared to expected development for the child's age. Now, if the child is premature, you would correct their age or how many weeks they're early and then compare the developmental stage at that point. And these are the categories they look at for seeing how delayed the child is. And another way to qualify is they already have a list of diagnoses that have a high probability of having either delayed or atypical development. And again, this varies state by state. So certain states actually did have mitochondrial myopathy listed as one of the qualifying diagnoses, but not all of the states have the same diagnosis list. So parents shouldn't be discouraged if they don't see mitochondrial myopathy on there. They just have to be evaluated to see if their child meets the eligibility criteria. And so early intervention is all home-based services, which is very convenient for the family, PT, OT, speech, and feeding. Usually it's free, but some places there is a small copay. And the main thing is to develop a home exercise program. And once a child does turn 3, they help transition the child to a special needs preschool if that's what is needed at that time. What can be frustrating for some parents is that some infants might not qualify. So even though they are delayed, they're not delayed enough to get services. And so if they are denied, then they can go through their pediatrician to get outpatient services through their insurance. And even there are some parents who, even though their child does qualify for early intervention, they only come about maybe once, at most twice a week, and they feel like their child needs more services than that, and they can still request outpatient therapies as well. Now, once a child reaches school age, a lot of times we see that they complain of fatigue. And so some of the things that we might recommend, depending on their grade level and academic level, they might need extra time on a test. They might need academic support. Sometimes they'll take breaks at the nurse's office instead of going to recess, or if they have a study hall, they might go lay down. Adaptive physical therapy. Some schools are more formal about it. Other schools, the parent will just talk to the gym teacher directly saying that my child has this disorder. They get tired more frequently. Please don't push them. And they're not making excuses. The biggest thing is we want the child to feel comfortable in saying that I need to take a break, as opposed to trying to please the teacher or trying to hide the fact that they might not be able to keep up. Another thing is an extra set of books. Even though nowadays a lot of children use Chromebooks, so they might not have as many textbooks. But what I realize is that I guess reaching middle school, some schools don't let children use the lockers. And so they have to carry all their books and their lunch and everything around with them all day for the whole day. And so that can be really exhausting. And so what we would suggest is that there is, if they do use textbooks, they can use one textbook, leave one textbook in each classroom, and then have one set at home so they don't have to carry it back and forth or carry it around the school. And then if there are a lot of stairs at school and the child gets fatigued easily, they can ask for an elevator pass. And then for all of these to be enforced in the public school, you can either meet with the teachers or administrators to have an IEP or a 504. And so just briefly, an IEP is an individualized education plan. And that's where you would get services for PT, OT, and speech and vision therapy within the school day, if the child qualifies. And the 504 plan is more for physical accommodations. So that would be any kind of assistive technology, preferential seating if they need to sit in front, if there are any vision concerns. If they get tired taking notes, they can have a scribe, which might either be a classmate or they can get pre-written notes from the teacher, or adaptive physical therapy. And just briefly on inpatient rehab, this is usually after a prolonged hospital stay for any kind of illness or orthopedic or neurosurgery. Inpatient rehab can be fairly intense. The patient has to be able to tolerate 3 hours of therapy a day or 15 hours over 7 days for insurance to continue with payment. And most of the goals are to decrease burden of care, pain management, caregiver training, and to increase functional independence. And these stays are usually between 2 to 3 weeks, depending on the diagnosis. And then outpatient rehab, which is what a lot of our patients have anyway, they need a referral usually. And like I said earlier, the frequency varies based on need and progress. If it's depending on a acute injury, it'd be short term. More for these chronic diseases, it's long term. And there is a copay, and there's usually a limited amount of visits per year. Sometimes, depending on if there's any low tone or anything, we would have the patients do other activities such as aquatic therapy, hippotherapy, which is horseback riding, adaptive horseback riding, or any kind of sensory integrative therapies, which may have limited availability, and not some of these specialized therapies are not always covered by insurance. And so now I'd like to transition to Hannah from occupational therapy.
Hello, I'm Hannah Hildenbrand. I'm going to talk a little bit more about equipment, and there'll be a little bit of repetition, but I will try to do my best not to repeat too much. So occupational therapy is the therapeutic use of everyday occupations with persons, groups, or populations for the purpose of enabling or enhancing participation. We define occupations as everyday personalized activities that people do as an individual in families and with communities to occupy time and bring meaning and purpose to life. So there are 9 areas, including activities of daily living or ADLs like bathing and dressing, instrumental ADLs like cooking and housekeeping, health management, sleep and rest, education, work, play, leisure, and social participation. Next slide. Dr. Santi? There we go. So we know that mitochondrial disorders are heterogeneous with a range of clinical features. The slide here highlights some of the clinical features that may impact engagement in daily life and indicate a need for occupational therapy and assessment, including ataxia, cardiac involvement, developmental difficulties, dystonia, encephalopathy, hypotonia, myopathy, peripheral neuropathy, spasticity, and visual system involvement. Next slide. So occupational therapists are skilled in assessing how symptoms impact function in daily life. Dr. Asante already mentioned earlier that OTs may be involved in various arenas, including early intervention. And there we would emphasize assessment and treatment of sensory processing difficulties, as well as stimulation of motor development. In the school and clinical arenas, OTs may focus on assessing need for adaptive technology to provide safe, functional positioning and to promote participation in daily activities. We also may direct environmental modifications and energy conservation during daily routines. And cognitive skills, particularly in memory and executive function, we may address that in collaboration with educators or speech therapists. And then the last few major areas include our role in supporting social emotional regulation, independent living skills, and transition services into vocational and work programs. Next. All right, so I did look at the literature and tried to find some studies involving occupational therapy. There are a few. I did find one retrospective study completed in the Netherlands. They found that children with mitochondrial disorders engage in a range of activities that resemble activities of typically developing children. That wouldn't surprise us, seeing some of the children we've seen here. The children are very active and engaged and really want to do things. We just need to try to find ways to support them, especially with the energy issues. So the activities that they categorized were across 9 categories, including self-care, house chores, therapy, school, computing, hobby, play, sports, mobility, and transport. And what the authors highlighted were differences within the study group that were found in level of independence, so assist versus no assist, use of assistive devices, and energy costs. So with the next few slides, I'll be focusing on what we would do as OTs to provide interventions related to those areas. Next slide. So this is going to be types of equipment that we use. This slide shows a variety of adaptive equipment and environmental modifications like the bars on the walls and such. We would use all this equipment really to focus on self-cares. The first image on the left shows a bath chair in a bathtub with horizontal grab bars. The chair has head blocks and chest straps, calf straps, and leg straps, and it's just used for increased positioning and for safety. Mostly this would be used for a child that really is dependent, but they are then able to participate to some degree. The back of the chair can be inclined to an upright posture or completely put flat. And the height of the chair may also be adjusted to preferred water level and transfer height, depending on the type of transfer that's needed. The second image from the left shows an adaptive toilet seat with adjustable footrests, armrests, and a safety belt or harness. This also has lateral head and neck supports, and they're optional. They're not, I don't think they're shown in this picture, but you can add those and customize them. And this supports the child with learning how to toilet training, or eventually daily use of the toilet. And it is mobile, so you can move it around. You can move it into the shower, you can move it over the toilet, or you can take it off of the base and actually slide it right onto the toilet itself. So actually parents have liked this because you can travel with it so that you can take it with you to other places. The third image from the left shows a mobile activity chair, and this also has footrests, armrests, lateral supports, and head and neck support. The chair can be raised, lowered, reclined, tilted, which is all very important depending on how much the energy the child has and where you may need to use it. There's also a variety of safety harnesses and straps to keep the child positioned safely. And the fourth image on the right shows a hygiene toilet system that includes all the adjustable features I've already highlighted. And this particular system is through child through adult. So it comes in different sizes and it can go into adulthood. So most important to remember with all this equipment is involvement of a collaborative team, licensed and trained in individual needs-based assessment and fitting, as well as training. The assessment needs to factor in where and how the equipment will be used, informed by the patient and the caregivers. Next slide. Okay, so this slide shows more examples of adaptive seating. Mostly this would be used in community-based settings. The first one, though, on the left, parents have used this in the home, but you can see these in the schools as well. It is a soft sitter, and it can provide the child with trunk and neck head support from a seating position. And there's similar looking chairs to this that are actually for car and air travel as well. But they are kind of labeled as such. The second image shows height adjustable armchairs with safety features like a lap belt and tip rear legs. And the third and final image shows a mobile activity chair that was actually in the previous slide as well. So these seating systems provide postural support to optimize body mechanics, enhance attention and engagement, and reduce energy cost. It helps to promote participation in fine motor activities like handwriting or tool use, even self-feeding, as well as participation in PE and specials like art and music. For all the equipment highlighted in the previous slide and this slide, it's important to work with a product vendor or specialists with familiarity to provide adaptive equipment and choices. Testing a demo or trial use can be really helpful to optimize functionality as well as carryover and integration into their daily lives. Sometimes the vendors don't offer that, but what we have found are like local lending closets and organizations that provide refurbished equipment. Sometimes you can go there, try it out, and it's just, they have a variety of things, not always something that will fit your immediate needs, but it's always a good place to check. There's a couple in Maryland, Equipment Connections for Kids, Ryan's Place Foundation, and then in Virginia, there's Children's Assistive Technology Services. Next slide. All right. So another area of focus for occupational therapy is vision rehabilitation. An OT with this focus or specialty training assesses the impact of children's visual impairments or vision loss on daily life. They would identify goals and needs for adaptive technology. They would provide necessary intervention training and caregiver education related to the functional goals. And then they may also link clients to community resources where they can also try out equipment or have more specialized training with some types of equipment. A lot of this equipment is very expensive, but some of it is lower technology as well. I just am going to provide a few examples. The first image on the left shows a child doing written work at a workstation magnifier. This device magnifies written or printed materials and projects on a vertical screen. So it can help children do math, drawing, writing, reading, and sorry, we have a call coming in. And it can also, for reading particularly, it can be quite helpful. And for children with particular mitochondrial disorders, you can get a video magnifier with speech output, and that may provide more support in reducing cognitive load and fatigue. So the second image on the left shows a child wearing tinted lenses or filters. And it can support children. They can support children with photophobia, and help to minimize glare and enhance contrast. The third image on the right shows a child using a robotic low vision distance camera. And this camera projects an image from the distance onto the user's screen. Next slide. Okay, so the last thing I'll go over is energy conservation. So in general, we know that fatigue can impact a person's function. And in mitochondrial disorders, the impact on fatigue can be a daily experience and one that needs to be accurately and fully understood and accommodated. So OTs can evaluate function and day-to-day experiences and then look at the impact of that fatigue that they may have. Then we would provide education and training in energy conservation focused on identifying essential and preferred tasks and performance level and assist needed. We'd analyze and monitor energy patterns, and we'd modify the activity and the environment, including emphasis on mindfulness to support engagement. And lastly, individualizing adaptive equipment, all of the equipment that we've already gone over. We would want to adapt it to their needs, to their activity, and to their space to try to conserve as much energy as you can. And lastly, in summary, next slide. I just want to sort of summarize that in caring for a child with mitochondrial disorder and to support them in participation in daily life, please just consider occupational therapy. We'll create an occupational profile, exploring the child's needs and wants, and identify what the child's goals are, what the family's goals are, learn about their habits and routines. We'll learn about where they live, work, learn, play, socialize, look at their cultural beliefs, interests, and values. And then we'll implement intentionally selected activities that they're interested in to try to enhance their engagement and just overall promote meaningful activity and participation. That's all I have. And I think, Nina, next? No? Or Beth? Okay.
Okay, perfect. Okay, my name is Beth Solomon, and I'm going to talk about speech language pathology services. Similar to the other therapists, we start at the NICU level and work all the way up till end of life, with the major concentration, as I've kind of combined here on this slide, with oral motor and safe swallowing functions, language development, auditory comprehension, expression, whether that's verbal expression or use of other types of devices, or even sign language if needed, and cognitive communication. Okay, so we're going to start off with what do we know? You can, yeah, that's perfect. What do we know? And I think from the top slide, we do know a lot about children and overall development, and the bottom slide being that of the mitochondrial children. But from a speech perspective, I think what we should focus on is the more of the neurological features, including the hypotonia, the seizures, the spasticity, movement disorders, the ataxia. We also worry about the brainstem dysfunction as it relates to respiration, as swallowing dysfunction, and other abnormalities in the thermal regulation, especially related to swallowing function. Our focus usually is for safe swallowing for nutrition and overall growth and development. And that may be nutrition by way of mouth or nutrition by way of other types of devices, such as an NG tube or gastrostomy tube if needed. We also will look at a child's overall functional abilities as it relates to social and communication, growth and development. This is all prior to school. And then once we get into the school system, keep them on a functional track for learning into the adult life. Just a couple of little nuances that many people don't realize, that swallowing involves greater than 30 paired muscles and nerves in a very well coordinated fashion in terms of function. That starts from just being able to understand what we're going to do, being attentive to a task, so that attention level is very important. And that all begins with the lips all the way down to the stomach. Individuals give little thought about swallowing, especially parents in the early days, because people just think we all should eat, but it's very complex and it always leads to specific types of disorders in different individuals. The average person swallows approximately 600 times a day. That happens more when we eat, less when we sleep. However, we still do swallow when we sleep. Aspiration pneumonia is the leading cause of death with patients who have progressive neurological disorders and muscular disorders. This was noted in 2001 in the New England Journal of Medicine. So we do underestimate swallowing dysfunction, and we underestimate the work involved in swallowing, especially with chewing of solid textures. Next slide. When we look at swallowing function, we can actually divide it into 3 phases. I sometimes divide it into 4. The first phase being that of, are we alert and awake enough to know what is actually happening, that cognitive piece to swallowing function. The first phase being the oral phase of swallowing. So that's the deliverance of something into the oral cavity, where we actually form a bolus or a ball of material and move it to the back of the oral cavity. In duration, that's 1 second long. It takes a little bit longer when we're chewing, but the actual movement of the food to the back of the mouth is only 1 second. The pharyngeal phase is a little bit more coordinated, requiring a set of movements of the soft palate, closing to the posterior pharyngeal walls, and some constriction with the pharyngeal constrictors, moving the bolus down into the hypopharynx. The larynx at that point moves up and forward, allowing the upper esophageal sphincter to relax and let the food into the esophagus. Again, this is 1 second. It's a lot of movement activity. So if there's any kind of discoordination, ataxia, this all causes disruption and can put a person into great risk for aspiration. The esophageal phase of swallowing is more the smooth muscles, and that can take in a child 8 to 10 seconds for the food to move from the upper esophagus down into the lower esophageal sphincter. Okay, oh, it's the diagram. So I'm just showing you the phases of the swallowing. Now, with mitochondrial disorders, most of the time the complaint of swallowing is not the first concern. But if somebody was to ask, what is the issue with your swallowing? Most people would say there's food aversion, food avoidances, food sticking in the throat. Some people just say, I'm not hungry. Sometimes you will have the food coming up and out the nose. You will hear a lot of coughing or wet, gurgly voices. There may be heartburn and indigestion feelings, and sometimes that just goes undiagnosed. Some of the secondary morbidities are the low energy and the fatigue, the weight loss, the dehydration, and aspirate pneumonia. Now, what ends up happening is what we typically see is that we have these long feeding times that last an hour to an hour and 15 minutes. A lot of that, you're wasting a lot of energy. So the amount of food getting put into the body is actually being expelled before the child even does any types of activity. So the long feeding times always needs to be addressed during our evaluations. In thinking about any complex child, you really have to start thinking a little bit out of the box. Now, we talked about coordination a little bit earlier and coughing and airway protection. We're going to talk about that in a minute. The fatigue and energy. We talk about mentation and neurological involvement, whether that is from the strokes or whether that could be from just cognitive development. There also are medications, seizure medications that will impact our both speech and swallowing function. So in treating these kids, we have to really think out of the box and go for other types of factors that may exist or coexist in terms of morbidities that will affect both the speech function and the swallowing function. So we get to an assessment phase of swallowing. So the first part when it comes to speech language pathology, and this could be whether they be the speech pathologist in the NICU, the hospital setting, it could be in the early intervention programs, there would be a clinical assessment. That clinical assessment would be a questionnaire, it could be observational assessment, feeding assessments, and certain types of information is gathered, let's say with the clinical swallow assessment. We then have to make decisions. Is the patient safe enough to eat or are they not? What kind of instrumental, if needed, studies should be performed? The first being the fiber optic evaluation is what you're seeing on the right-hand side, where a small tube is put into the nose and you are actually able to look through the nose at the upper esophageal sphincter. You can look at the larynx. You see on the bottom some green dyed food that is in the posterior laryngeal structures that is just sitting there and pooling and has the ability, and you can see, I don't know if you can see this right here, the food going down into the windpipe. After the fiber optic eval, it's a good exam. You could use that. Some kids don't like the tube. They may not cooperate. It's hard to be the jack of all trades and drop the tube, and you have to be specialty trained in speech to do something like this or work with an ear, nose, and throat physician. The other option would be a video fluoroscopic evaluation of swallowing function, or better known as a modified barium swallow. The GI assessments, which you would then potentially refer a child off to, would be the esophagram, gastric emptying studies, manometry, or a further lower GI endoscopy. I'm going to come back to the video fluoroscopic assessment on the next slide, please. So the video fluoroscopic evaluation of swallowing is the gold standard. Some individuals don't like it because they're always afraid of how much radiation is a child getting and what are we going to get from the study. But in reality, it is a study that provides a lot of information from a physiological standpoint, only giving you the amount of radiation that you would be getting if you lived on the earth for 32 days. So it's a cost benefit factor of whether you want to have that study and what you're looking for your questions. It allows for direct visualization of swallowing physiology, as you can see on the upper right-hand corner. It's a systematic evaluation if done correctly, giving liquid, puddings, cookies, depending on what the child may be having trouble with. And we're looking for not only overall physiology and what is safe for the child to eat, but we're also looking for laryngeal penetration, aspiration, and potentially silent aspiration. It has ability to have different impairment level analysis. Next slide. When it comes to the larynx, and you're seeing some aspiration in the front here, there's 3 ways we can define this as laryngeal penetration, where there's entrance of food into the upper laryngeal vestibule above the true vocal folds, and that's where you usually will get that wet, gurgly vocal quality or a little bit of a cough. You have aspiration, which most people are very worried about, and that is when secretions or liquid or food go below the level of the vocal cords, and there is a clinical sign where you cough it out or you throat clear it. What's the most dangerous is probably the silent aspiration, where you will aspirate saliva, liquid food without any type of sensory or motor response. And this happens quite a bit, especially during treatment type studies and research, where you may have somebody who has been aspirating and you're following them with a severity scale. You may not know that they are maybe getting better, or you may think they're getting better because of the treatment study, but actually they've kind of transitioned from an aspirated state to a silent aspiration state. So it's something that you always need to be watching, that swallow assessment for the physiology, especially during the research. So feeding and swallowing considerations in the mitochondrial population, these are a few that I kind of put together. Duration of the meal times, what is the positioning like? What's that infant state during the meal, prior to the meal? Do they fall asleep? Are they that fatigued? Do they have types of arching or extension? Is there nasal flaring, any type of cyanosis? What are the respiratory patterns? Do we have any signs or symptoms of laryngeal penetration or aspiration, and coordination with the hiccups? Next slide. From the swallowing studies, we will give you an interpretive type of a result. Is the child safe to eat? And what is the child safe to eat? And what is that aspiration risk? From there, we would then make those recommendations, whether it be for solids versus liquids or combination thereof. There is an international dysphagia diet, which we follow here at NIH because we see so many patients from around the US as well as the world, that we try to do everything as systematically as possible, so at least our results are comparable to something on the outside. We may use supplemental thickeners or thickening agents if needed. We may use adaptive types of cups or dispensing types of cups or straws that could be used to help with coordination. Appropriate seating is then provided, as well as exercise, again, for swallowing. And all of this is taught to patients' families. They have repeated evaluations depending on what is happening with their overall care. And turning to speech, language, and cognition, this is a busy slide. I'll focus first on the oral motor, which is the lower right quadrant, and the respiratory functions. We will quickly look at that in terms of our evaluation and our treatments, to look at the coordination of the movement patterns, both with the articulators, the tongue, the lips, the cheeks. We will also we'll go to the upper left, the upper left for the cognition. What is that attention, the memory? And over time, as the child gets older, we're looking at more orientation, sequencing, knowledge, and calculations. When it comes to speech function, we look at language being what I would call the Bible. It is the foundation work, the framework of how we are communicating. So it's, what does one understand? How do they express themselves? Is that with a word approximation? Is that with a full lexicon, then syntax, putting a couple words together in phrases? And is that all appropriate in terms of meaning? when it comes to the actual delivery, speech is your vehicle, that being the voicing, your articulation, the actual sounds, and are those sounds clear? The resonance, are they hypernasal or hyponasal? And the co-articulation, meaning how do the sounds come together with all of the speech functions. So through all of this, we are looking in the pediatric realm with communication intent initially. Are they verbal? Are they nonverbal? What is the verbal output? Are we sounds, words, combinations? Are we utilizing full language functions such as the pronouns, adjectives, sequencing, and all of this goes through school and school-age speech language pathologists? What is the actual speech and vocal quality? Are they hoarse? Are they nasal? What's the fluency level? How do we then provide the appropriate therapy to actually make them better understood? And knowing that they're having lots of therapies, what is going to give the child the biggest bang for your buck in terms of intelligibility for overall development and social. We'll look for oral motor weakness and the dysarthrias. Some children do require augmentative communication, and we can help in terms of finding those best supports for augmentative. And we can't forget the hearing and the hearing and the vision loops in terms of speech function. I'm going to leave it here, but then we do continue all the way through adulthood in terms of treatment, but I'd let Mina come on next.
So what I have to say is going to be kind of repetitive in terms of what Dr. Asante, Hannah, and Beth have talked about, but the purpose is also to ensure that everybody understands that the need for rehab medicine is great for people with this population. So physical therapists, we are people who examine and treat individuals of all age, and goals of physical therapy are to maximize mobility, manage pain, manage fatigue, improving strength and range of motion, improving physical function and fitness, and then trying to look towards the future and prevent any future problems. So as I tell all my family members, the patients, I said, our goal is to help you walk from one location to another location. As Dr. Asante has mentioned, early intervention is the promotion of gross motor skill development and addressing positioning and muscle strengthening. At a very young age, OT and PT overlap quite a bit. So you may see PTs and OTs functioning the same, but our focus is different. I may focus more on the gross motor part of it, and OT may focus on more of the sensory or fine motor issues. But we may end up doing the same thing. School-based therapy, as Dr. Asante mentioned, is just, and PTs within the school system support mobility, getting around the stairs, getting access onto the playground, working with OT in terms of toileting and going to the bathroom. And then also educating the teachers and the gym teachers and the classroom teachers about energy conservation strategies, especially in this population of children with mitochondrial disorders. Next slide. Oh, I guess. And then as they get older, we transition on training, endurance training and independence in physical activities. And also we support with assistive device and adaptive sports because life lives around outside of physical therapy. So we want to make sure that they are able to participate in sports related activities. All right. Very important in this population, we use an individualized approach because everybody's progression will change. And this is true for any population, but especially so with children with mitochondrial disorders, especially with the energy conservation piece. We focus on a gradual progression, starting with low intensity exercises, and then discuss how to increase the duration and tolerate it. We discuss a variety of exercise modalities, and Dr. Asante has touched on that in terms of aquatic therapy, therapeutic riding, but we may look at other activities Within the environment at school, outside, we can talk about swim team, we can talk about karate, dance, other ways that the child would be engaged and interested. And then most importantly, education and supporting the child by talking to the family about these energy conservation techniques. So, next slide. Okay. So to reiterate, the most important we want to consider is to avoid overexertion. And children with mitochondrial disorders may experience fatigue easily. It is important that the child and the family understand signs and symptoms in terms of whether they are fatigued because the child may not express themselves or may not be able to express themselves. Things that you may want to look for if the child pulls themselves out and prefers to do quiet activities such as reading a book or doing a puzzle if they're young enough to do that, or they just may sit on your lap or they'll kind of pull on you to lift you up. Those are the things that we tell parents to kind of look for. One of the questions that I get asked a lot is how much should my child exercise or work or participate? I let them know that I don't have an answer for them. What they need to do as a parent is to see how they recover the next day. And if they are so exhausted from today's activity that they require to like call in from school or call in, like don't go to school, then you know that whatever you did today was too much and then have to cut back. In the moment, it's hard for them to understand if it's too much, it's the next day recovery. It's also very important to collaborate with other healthcare providers. And as you can understand, we work very closely with our team members in terms of physiatry, OT, and speech, but also other providers in terms of primary care physicians, geneticists, and any other specialist. And then also monitoring their progress over time and seeing them on a regular for regular assessments. Next slide. All right, so I wanted to go over generally in terms of the types of exercise. Dr. Asante, you can click through and all that. So we talk a lot about strengthening and aerobics, but what are some of those exercises? So strengthening could be isometric, active range of motion, resistance band. Stretching will include things like for elbow and hip and knee, and especially ankle to prevent contractures, which would limit mobility. And then aerobics would be something fun like swimming, walking. And then if they're dependent for mobility, then wheelchair mobility would be included as well too. Okay. Next slide. Okay, we could kind of go through all these. These are just some suggestions of stretching exercises. And then we talk about water-based exercise. I know Dr. Asante talked about that, but these are some ways that we can make it fun. We give them little barbells and playing games, Marco Polo. Those are all for kids that are old enough to be able to play these games. But for the younger kids, just being in the water with the parent and appropriate flotation device is enough to make sure that they maintain their mobility and strength. The other thing that you have to kind of look at is the environment, the temperature of the water. Some kids may not do well with the warm water, and you need to have a cooler water. And it's the other way around. Some kids may do well with warmer water. Most community pools are cooler. There are some pools that tend to keep it at a warmer temperature, and you can get that information from the Arthritis Foundation because people with arthritis require a warmer water environment, and you can look that up online. Next one. Okay, so basically, we just want to make sure that kids stay active. We can go through this forward. We want to make sure that kids stay active. And the most important thing is to keep it fun. I think Hannah went through a lot of seating options, so we can kind of scroll through that. I did want to go through standing frames. So one of the most important things that as a physical therapist that I try to do is make sure that children are up and standing generally around the time the typically developing children will be standing up. So that's around 12 to 18 months. And there are a variety of standing frames available on the market. So they have mobile standing frames, which is for more older children, but then they have standing frames like that little one on the right, where they're standing and there's a tray in front of them so they can work on some fine motor activity with the tray in front of them. Go ahead, next slide. You can click through. So these are all just a variety of mobility devices. You got walkers, you have scooters, you have a motorized wheelchair. And the far one on the corner, the far right corner, is a little tiny car. This is a Go Baby Go car, and this is a program that was developed by the University of Delaware, where they adapt those motorized cars that you can get at Toys R Us, well, not Toys R Us, but any other toy store these days, and it's adapted for children. And the idea is early mobility enhances academic improvement, and just if kids can move around in their environment, they will interact with their peers, their family members, and it enhances a lot of learning. So we try to focus on early mobility, not just early standing, but early mobility as much as possible. And this is one avenue to get to it. Some non-traditional therapies that a lot of parents have asked me about. One is the compression suits. There is no research to show that it is helpful, especially in kids who have low tone or spasticity, but there is no research to show that it is harmful. So my advice to family members is that these generally are not covered by insurance. So if you have the resources and it helps your child, it doesn't hurt the child, but I would rather the families use those resources towards like swimming or therapeutic riding, which we know is helpful. But that's just something that we talk to parents about if needed. And then the other two are inspiratory muscle training, which we are learning a little bit more. And I'm recommending it for older children, but not for so much for little children. And then kinesiotaping in terms of for contraction management and muscle facilitation. But that you would need to work with a provider who is qualified to do this. Next time. Okay. And we talked about transitioning to adult programs. So one of the, it's very difficult for families to realize that they are leaving the school system at age 21 or 22, depending on your state, and then trying to assist them to transition to an adult program. And the focus would be on independence of daily living, vocational skills, and then referral to adult services. Any questions from anybody? All right. Well, we want to thank you for inviting us. As Dr. Asante said, it's been a long time coming, and thank you for having us here.
Yeah. Eliza, did you have a question that you
Yeah, I'll
wanted
just leave us with one question, since I know we're a little bit over time. I was wondering, so many of our patients with complex disabilities, especially our more severe affected patients with mitochondrial disease, are very dependent on their caregivers for a lot of these tasks, which can be very physically laboring on them. And so what recommendations do you make to parents and caregivers to maintain their own health in terms of lifting heavy children as they're growing or lifting heavy equipment? Do you have any specific recommendations that you make to caregivers for those purposes?
So I'll answer first and then I'll let others answer. So in terms of lift devices, there are a number of external lift devices that are available, but what happens, the issue is they take up so much space in the room, in the locations, that a lot of family members are not able to utilize them properly, or they just abandon them. Even though we may recommend a Hoyer lift or some other type of lift, they end up not using it. The other way is to do an overhead lift, but then you run into construction issues. So some states are a little bit more generous than others in terms of providing resources for home adaptations that they can use those to install those lifts. But It is a challenge. We do recommend, we counsel the family members to make sure they take care of themselves. Depending on what state you live in, you can get respite services, so the parents can, the family members can get a little bit of time for themselves, and then they have a caregiver that comes to the home. So it's, and again, it is state to state dependent. But yes, to answer your question, we do recommend home lift devices, but those are challenging because of space issues in terms of family members.
Yeah, and the other thing is like all that equipment we showed, the chairs and the bathing equipment, all those things, it's not just energy conservation for the child, it's for the parents as well. So, and making sure they fit the child, and it's the proper height for doing transfers if they don't have those lifts, if they're actually doing dependent transfers, or even if the child's helping, but making sure that the child is supported when they're doing activities not only helps them, but it reduces the burden on the parents. We often will meet parents and they're sitting in the bathtub with the child, or it's taking two parents to do the bath because of that. And even with toileting as well, there's all kinds of things that people will try. So really helping them maybe link to resources for getting that equipment, even if it's using some of those refurbished equipment in the local community.
Thanks.
Well, Liza, maybe we're gonna bring this to an end.
Yeah, I was going to say, I think that was it. We didn't have any questions in the box, and so I think we're good.
Yeah. Well, thank you so much for your moderation, but also to the speakers. A very interesting topic, and one that we think certainly has value for both clinicians as well as patient families to better understand the role of rehabilitative medicine. So thank you. I know it took us a while to get a schedule, but I'm glad we finally made it work out. Appreciate your joining us today. With
Thank
that, I'm
you.
going to wrap up this week's or this month's webinar with just a reminder that we do this monthly, the second Monday of each month. And in October, we will have a topic on diagnosing and managing mitochondrial disease in Malaysia. So we started this last year with an emphasis on understanding clinical care of mitochondrial disease patients in different parts of the world. Really interesting, and I think everybody can learn from it. So if you know someone, particularly someone who may be abroad, not based in the States, and might find this interesting, please pass along the invitation. And we always love to hear from you if you have ideas for other topics going forward. Thanks again to the speakers, moderators, everybody today. And with that, we're going to end this month's Bench to Bedside webinar.